We are live now. Casper, the floor is yours.
Thank you. And good morning and welcome everybody to this exciting session on the new pediatric guidelines. So my name is Casper Lortzen. I'm an ED physician in Denmark. And as a conflict of interest, I'm also in the ERT task force of ILCOR. I'm looking forward to moderating this session together with Patrick van der Voorde. During this session today, we'll have 4 exciting presentations. The first by Jana Jakov. First we'll have Patrick giving an introduction, and then following by Jana, and then we'll have Dominique Bierent and Nigel Turner presenting in the end. And we will have the opportunity to ask questions along the way during the session. So please use the chat function to ask your questions. And then in the end, after all presentations, we will have room for the questions. So I will start out by giving the word to Patrick, who will give an introduction to the new guidelines.
So hi, it's with really great pleasure. It has been a trajectory of many years. First of all, maybe showing my conflict of interests. I'm no real conflict of interest, only intellectual, as co-chair of the Pediatric Science and Educational Committee. It's been a trajectory, like I said, of several years. Jana calculated it. It took us as long as the last Star Wars film, about 3 years. Especially given the COVID circumstances, this was not an easy trajectory. We started with the guidelines in 2015, and at that stage, the ILCOR, and those who've seen the introduction of this Congress, the first sessions already got it explained by Gavin, how the process of these guidelines was done. But at 2015, ILCOR changed this evaluation to a continuous process instead of the 5-year process. Still having task forces doing systematic reviews in an expert grade-driven way, but leading to actually ILCOR recommendations on a yearly basis. As these were all systematic reviews, very strong, built through systematic reviews, there were only a few of them, and as is often the case, the strength of the treatment recommendations was most often very limited, with a lot of justification and evidence to decision discussion, but still, what we experienced down the line was that with these systematic reviews, it would be it's an interesting process, but for building really on evidence, we would need to explore much more topics, and ILCOR also invested in doing scoping reviews, having a larger scope, and evidence updates. What these are is explained in the chapter, so I won't focus on this. But this, just to tell you, this process generates some answers, but even more questions. And going from this sort of evidence evaluation to guidelines is not an easy thing. It needs a lot of additional work, and that's what we experienced. But it's clear that despite the low certainty of evidence, there is need for guidance to all of us who are doing clinical work. And that is what ERC recognized, and where we decided as a resuscitation council to stick with the 5-year approach, where we every 5 years present an update of our guidelines, in terms of also being applicable to our clinical situation, where we would not want to continuously have to change. We built these guidelines according to the agreed to protocol, meaning that having each of these steps, and like was said in the opening section, these are probably the most rigorous guidelines ERC has ever made, including the evaluation of evidence to decision, including thinking about applicability, including stakeholder involvement. And you all had the opportunity in October to comment on them, and we did make adjustments aligned with some of the comments we got. For the pediatric guidelines, we eventually explored ATP costs. Some of them we could find our evidence in the ILCOR COSTAR that directly evaluated a specific P cost. But for others, we looked at guidelines from existing societies and evaluated their applicability and quality, or we did ourselves a rapid review, which is still a structured review approach. And finally, we also looked at indirect evidence if there was nothing else to build our question on. We were confronted with COVID, as you know, and therefore the process was prolonged with a year. In that year, we also produced COVID-specific guidelines on the road. And because of this break, in a way, we did a full search update of each of these P costs in June 2020. And finally, and maybe most importantly, acknowledging that for a lot of things we have low certainty evidence, we spend a lot of time evaluating the evidence to decision, taking also into account the whole formula of survival, meaning educational efficiency, local implementation, trying to get these guidelines as simple, as uniform as possible, but acknowledging the fact that they are contextual. They will depend on your resources, they will depend on your organization, and also highlighting that these are the European resuscitation guidelines, and they might differ. We tried as much as possible not to differ them from other societies, but depending on our evaluation of each of these three parameters, science, education, implementation, we ended up with some decisions that might differ from other resuscitation societies. We will focus in this hour on what's new, but I can already give you a few key concepts. We define child as between 0 to 18 years, so only excluding the newborn at birth. However, acknowledging that adult guidance can be used for anyone who appears to be an adult. We emphasize the concept of the competent provider as a sort of a uniform definition for a lot of situations, saying that somebody who performs or leads a procedure should have the sufficient knowledge, skills, attitudes, expertise, and training to do so at the level of this demanded by society. You cannot, for each of these procedures, define what is that level, so there's a lot of self-reflection in there. And importantly, we emphasize the team-based approach throughout our guidelines, as we think this is the way, and there is evidence for it to improve how we treat and care for children that are seriously ill or injured. And as you will see in the lectures to come, we do not specifically mention the chain of survival as such, but the whole chapter is written along this way, meaning we equally, and that's why it's a big chapter, about 70 pages long, we equally evaluate the pre-arrest condition, trying to avoid cardiac arrest, the basic life support, the advanced life support, up till the post-resuscitation care. And each of these topics will be further explored by our illustrious panel. I rest my case. Casper.
Yeah, so thank you very much for that presentation, Patrick. Our next presenter is Jana, who will talk about the pre-arrest management. So I will give the word to you, Jana.
Okay, thank you. I will try to share my screen there. Okay, so I will talk about the first link to the chain of survival, which is pre-arrest. For this presentation, I have no conflict of interest working in pediatric ICU. So what we know about childhood cardiac arrest is that most of these cardiac arrests are secondary to severe illness or injury, which makes them really different from adult cardiac arrest. Therefore, we need to emphasize the pre-arrest phase interventions even more than in adults. And we did that in the pre-arrest phase chapter by giving specific recommendation on recognition and treatment of respiratory failure, on treatment of cardiac failure and neurological and other emergencies. We believe that the earlier you start appropriate interventions, then the better are outcomes for the children. So as pediatricians know, it can be really tricky to recognize which children actually are critically ill and which are only irritated by hunger or something like that. So we need a system to look at these children, and by this system we believe that it's starting with quick look and then going through A, B, C, D, E. And as Patrick mentioned before, we also believe that working as a team can increase our efficiency and recognition and treating critically ill infants and child. I will, in my presentation, mostly focus on some changes we made. So there are some changes for normal values in children. You can check this in guidelines. Based on the new evidence, we revised our normal values for respiratory rate, heart rate, and blood pressure. We no longer recommend the formulas for estimation of child's weight, but we rather recommend to rely either on parents' estimates or to use a length-based method. Ideally, this should be also corrected for body habitus. As you can see on the picture, based on how the child looks, there might be as much as, for example, 5 kilo difference between those children, so it can make a difference in your calculated doses. When it comes to management of respiratory failure, we now recommend to give oxygen only if the measurement of SpO2 is showing you that it's below 94%, and use as little supplemental FiO2 as possible. If it is impossible to measure reliably SpO2, and this might be the case in some emergency situation, then we still recommend to give oxygen at high flow and then titrate as soon as possible. And this is applicable to children with signs of respiratory and circulatory failure. If hypoxemia is not responding to low flow, then you can consider high flow nasal oxygen or non-invasive ventilation. And actually there was not enough evidence to recommend one over the other. We believe that bag mask ventilation should be really the first line recommended method to support ventilation in children. And by this statement, we want to sort of making a shift in thinking of some people from we need immediately intubate this child into we need to immediately efficiently ventilate this child. And this is more important than to rush into intubation that is not prepared well enough. And there's actually some data on it, and you can check this in our guidelines why we decided to recommend this. If you decide to do tracheal intubation, then we recommend to do it only if you are competent to do so, following a well-defined procedure and having all the materials and drugs, using appropriate medication to facilitate intubation. We now recommend to use only cuffed tracheal tubes for pediatric life support with a monitor cuff pressure. What we try to even more say that we want to avoid prolonged laryngoscopy and or multiple attempts. And there is actually quite enough evidence that a lot of emergency intubations are done after more than 3 attempts to intubate the child. And as well, we know that multiple attempts intubation are actually worsening the outcomes of the children. Capnography should be mandatory for all intubated children, and if you are competent, you can use point-of-care ultrasound for recognition and management of respiratory failure. When it comes to the circulatory failure, there was one big decision, or well, for me it's big, but I don't know if for most of you, we decided to go for a fluid therapy bolus to 10 mils per kilo, and this was after severe discussion, and we want to say that this does not necessarily mean that you might limit the total volume of fluids that the child might need it, but it rather means that you should reassess more after each bolus. And in some cases of shock, this still might need that the children might get as much as 40 to 60 mils per kilo during the first hour, but there will be much more reassessment. We recommend to use balanced crystalloid solutions if it is possible. If not, then you can still go with normal saline. And in a hemorrhagic shock, we recommend to limit crystalloid boluses to minimum and use blood products or full blood early. Also, we are stressing the importance of vasoactive medication starting earlier and titrate to achieve desired goals. And this is true in not only in septic shock, but also in some hypovolemic types of shock. For specific kinds of shock, we, for septic shock, recommend to consider also stress dose hydrocortisone if the child is not responding to fluid and vasoactive support. Of course, start broad spectrum antibiotics. For tangent pneumothorax, we decided to change the primary site of entry for needle thoracocentesis or emergency thoracostomy to 4th to 5th intercostal space, slightly anterior to the mid-axillary line. And that's in line with what the adults are recommending. But you can still use second if it's an acceptable alternative in children, but for the consistency, and it is as safe as the second, or maybe even safer to use the 4th to 5th. And also you can use point-of-care ultrasound if you are competent for recognition and treatment of circulatory failure. For unstable bradycardia, and there's not much change in it, consider atropine only in bradycardia that is caused by increased vagal tone. Unlike in the previous guidelines, we are saying now that there's no minimal dose for small infants. And unstable tachycardia, well, we are now increasing the 3rd dose for immediate synchronized cardioversion from 1 to 2 joules to 4 joules per kilo for decompensated tachycardia. And for compensated supraventricular tachycardia, we recommend higher doses of adenosine, especially in small children. You should use the higher dose. When it comes to the neurological and other emergencies, we also recommend to recognize and treat quickly by using ABCDE approach. And you can find in our guidelines also specific stepwise recommendations for pediatric seizures, status epilepticus, pediatric hypoglycemia, hyperkalemia, thermia, heat stroke in children, pediatric status asthmaticus, and anaphylaxis in children. So this is what you can check in our guidelines, and I am finishing with the last top recommendations concerning the pre-arrest phase, as you can see them on the screen, and you can also find them in our guidelines. Thank you for your attention, and thanks to all the people who work together to get you to these guidelines.
Thank you very much, Jana. This is really a big chapter to talk about, so you did it perfectly in time, I think. Yes. And I do see questions coming. I would prefer to keep them for the end and move immediately to our second speaker. Some of them might get explained in the things to come. Our second speaker is Dominique Biaran from Brussels. I can say the Biaran, from Brussels. She's an intensivist and immersive physician. She's been with ERC and with guidelines since a very long time, and I'm very happy. She's looking very scared now.
I'm sorry, but I try to share my screen, but my slide disappeared. That's funny.
Spooky.
No, spooky, as you say. I will try again. Sorry.
No problem.
Otherwise, I can do it without. Well, just check.
That would be interesting.
Yeah, that's it. They closed. I don't know why. Okay, sorry for this. So I will speak about basic life support once I got this to share. Now here they are. These are the surprise of internet and all those very, very sophisticated things. So I don't have any conflict of interest, well, at the point of financial interest. Of course, I am an old member of ERC, and I'm vice chair of the Belgian Resuscitation Council, but many of us have those problems. Patrick told you that we are taking care of children, except for the real newborn in the delivery room, and of course adults, but we can decide as pediatrician who is adult and who is not. So if you think somebody is an adult, you can consider to take care of him as he is an adult. So the first question is that for BLS, who is the rescuer? And that's important because we discussed that for years. Who will do what? Who has to be trained in pediatric? Who is doing rescue breath? Who is not doing that? So simplification is always good. Who is trained for EPBLS, meaning pediatric BLS should do BLS. Who is trained for adult BLS should do adult BLS. And if able or willing to do it, it will give 5 rescue breaths to the child, and the untrained should be assisted by the EMS dispatcher, who are now able to give indication for doing pediatric life support. Or if the untrained rescuer is not willing, just ask him to do chest compression only, because it is always better to do that than doing nothing. 3 major point change in the pediatric basic life support. Well, that's my point of view, but the first one is that we speak now of competent provider, and they should use bag and mask ventilation as a 2-person approach. That's the first point. The second point is that we should call the EMS system as single rescuer just after the 5 rescue breaths. I'm very happy with this change because now we are in line with the adult algorithm. So same approach, just at the 5 breaths. Next point that has been changed is you don't have any clear signs of life, go on for chest compression. And how can we manage that? We will, everybody has his mobile phone either in his hand, most of the time it is in the hand, unfortunately, or in the pocket. So when you are single rescue, take your mobile phone and immediately call the EMS system or any help you know in your country or in your system, and just after the initial rescue breath, so that with the speaker function being on, you can do, if you are able to do that, that's more for women than for men, of course, but you can at the same time call the system, the MS, and start chest compression, at least while you are waiting for the answer. That can take a long time, as you know. If, of course, you don't have any phone available, then, like usual, perform 1 minute CPR before leaving the child. So immediately proceed to the chest compression after the rescue breath, unless you see very clear signs of circulation, meaning movement or coughing. Of course, as usual, you should avoid incomplete recoil. We also move for the two-thumb encircling technique for the single rescuer, even if he is not a competent provider, because as you know, and we know that for a long time, it is certainly as well as a two-finger technique. The end of time is not very different. With the two-thumb, you always performs better. It means that the depth, for example, is better. With the two-finger, the quality is suboptimal, and people are really early having fatigue. But of course, you can always continue with the two-finger if it is better. But we should taught now the two-thumb to everybody. I said bag and mask ventilation is really the first line for rescue breath, and that's probably what has been brought by the COVID. Funny story, we all live for no more than 1 year, and competent providers should use it with oxygen or without oxygen if you have any. The pocket mask can be used for larger kids, children. A few other things have been changed. In trauma, we should prioritize the CPR more than the spinal immobilization, and avoid putting AED except if you have a child with something like electrocution or anything else that can for sure give a rhythm abnormally. Bleeding should be one of our priority in trauma. Treat the hemorrhage with pressure, and if it is not possible because the hemorrhage is really important, use a tourniquet. And for the foreign body airway obstruction, there is no change, but we do not recommend up to now to use the devices that are now on the market, because there is no evidence that this is better than our maneuver. But of course, this can be the subject of studies. Medial forceps, if you can use it, can be one of the options to remove the foreign body. A few words, well, very short, on the lateral recovery position. In cardiac arrest, we can see breathing movement for up to 2 minutes, and it can hinder the early detection of an abnormal breathing or of a cardiac arrest. So we have to talk to rescuer to repeatedly assess breathing and reevaluate the victim at least every minute to be sure that after having put the child in recovery position, we are able to detect the cardiac arrest if occurring. So eventually, what's new in BLS? There are plenty of things that are new in pediatric BLS, and I think we made very important progress so that we can simplify the teaching, being in line with adults, using a more efficient technique, which is the two-term uncertain technique. The call comes early. Bag mask valve must be used by competent provider. We have several few difference in trauma, AD, and recovery position. Thank you very much.
Thank you very much for that great presentation, Dominique. And it's great to see that we have the questions still coming. As Patrick said before, we will leave some time to answer some of these questions after the next presentation, which will be from Nigel Turner, who will talk about the pediatric advanced life support. So I'll give the word to you, Nigel.
Thank you very much, Casper. Can you see my slides? He's nodding, so he can. My name is Nigel Turner, as has just been said. I'm a pediatric cardiac anesthesiologist in Utrecht in the Netherlands. I'd like to thank the ERC for the invitation here, of course. And what we're going to do, like the other two speakers, is focus on the changes which have been made, in this case, in the pediatric advanced life support algorithm. I have no conflict of interest for this talk. But I do have a problem with my slides. There we are. That's good. This is the new pediatric ALS algorithm, which contains a little more information than the previous version. The top part of the algorithm, with the main actions to be taken during an arrest, is essentially unchanged, although we have been a little bit more explicit with the timing of adrenaline. In the lower part on the left is the box with details of the interventions. And again, much of this is unchanged. But I just want to highlight a number of areas to discuss in more detail, namely the ventilation strategy, emphasizing ventilation and avoidance of hyperventilation at any time and of hyperoxia during the post-ROSC phase. Secondly, the ventilation rate following intubation. And thirdly, we made some changes to the shockable rhythm protocol. Let's start logically with A and B. As has been said by Jana, the bag and mask ventilation technique is the standard for professionals during pediatric ALS. The two-person technique should be used unless a single rescuer can guarantee adequate ventilation as assessed by chest rise. Intubation should only be attempted by a highly competent airway operator and the tube position checked by capnography. I think this is important. Even more important is to emphasize that ventilation remains an essential component of pediatric resuscitation. Now, probably the most important change we've made in 2021 is the ventilation rate during continuous chest compressions following intubation. The new guideline advertises nothing. It advises a minimum volume similar to that used in critically ill children. The slide shows the approximate rates, which in most cases are in the sub-physiological range. For instance, 12 per minute by older children and 25 per minute in infants. I just want to take a minute to explain our reasoning behind this change. We are all aware of the potential dangers of hyperventilation, particularly the effects on cerebral vasoconstriction and impeded venous return. However, this work was done in animals and in adults, and the pediatric working group found it difficult to extrapolate these to real children. One study which has influenced our thinking was an observational study by Sutton et al. Of in-hospital pediatric cardiac arrest. They found that a higher ventilation rate was associated with improved survival. You'll notice straight away in this study that the average ventilation rates were much higher than that previously recommended, being 10 to 12 per minute. 33 breaths per minute were used in survivors and 27 breaths per minute in non-survivors. So people weren't following our original guidelines, as Patrick said in the introduction. A second study which influenced our thinking was an animal study by Lopez, which was in piglets and showed similar ROSC rates with ventilation rates from 10, 20, and 30. The higher rates were not associated with a hemodynamic compromise, but they were associated with a lower CO2 and lower cerebral oximetry as measured by NIRS. So this is maybe an important point to emphasize again. If we increase ventilation after intubation, it doesn't mean that we are trying to hyperventilate the child. We must always be careful to avoid hyperventilation. Moving on to oxygenation, we still recommend using 100% O2 during the arrest. We've been guided in this by the systematic reviews of Patel, amongst others, looking at adults, showing that intra-arrest hyperoxia is associated with lower mortality, while post-arrest hyperoxia is associated with a higher mortality. We also acknowledge practical difficulties in measuring oxygenation during resuscitation, and also note that attempts to titrate oxygen, particularly in the pre-hospital phase, can lead to hypoxia. For the post-resuscitation phase, we follow Patel's finding, as well as that of other studies suggesting that hyperoxia can be harmful. We are also considered a study showing an association between hyperoxia and mortality in children on ECMO. So our advice remains to give 100% oxygen during resuscitation and to titrate this post-ROSC to a saturation between 94 and 98 in most cases. Lastly, I want to mention a few aspects of shockable rhythms. The shockable rhythms occur in children as a primary rhythm in 10 to 10% of out-of-hospital arrests, somewhat more frequent in hospital. An important point to emphasize, which many of us do not appreciate, is that a shockable rhythm can be a secondary rhythm in children. So it's important to attend to this issue. The basic algorithm for shockable rhythms is on the slide and is essentially unchanged. We still recommend 4 joules per kilogram using a non-escalating protocol for the first shocks. In maintaining these recommendations, we have drawn heavily on the excellent systematic reviews of Mercier, which looked at energy doses for defibrillation in children, which concluded that a large range of energies are effective and that a clear association of harm was only seen in energies above 10 joules per kilogram. We've also included advice on refractory shockable rhythms, which has also been influenced by Mercier's findings. We recommend that if a shockable rhythm persists after 5 unsuccessful shocks, one should consider increasing the energy dose up to 8 joules per kilogram, or to the maximum output of the defibrillator in older children. And the pad position should also be checked, and maybe one should also consider changing the position of the pads, for instance, from anterolateral to the anteroposterior position. Lastly, a couple of words on in-hospital arrests, which can happen frequently in children who are already monitored in an intensive care unit or operating theatre or in the cath lab, and who can be defibrillated immediately. For this situation, we acknowledge that immediate defibrillation can be beneficial. And in some cases, particularly in cardiac surgery, cardiac massage may even be ineffective or harmful. We therefore followed the guidelines of the Pediatric Thoracic Surgery Society and also adult guidelines in recommending up to 3 immediate shocks before starting compressions, only after these important situations. So to summarize, the main changes are bag and mask ventilation is a standard technique for all professionals. However, if an expert has intubated the child, then continuous chest compression should be given, and the ventilatory rate should be similar to that used in critically ill children. And finally, we recommend a stacked shock protocol for monitored children who can be immediately defibrillated, and increasing the energy level in refractory rhythms. I thank you for your attention.
Fantastic.
So no applause. That's sad, eventually.
I always wondered what we should do with adults who behave like children. Are they then? There you go. What I didn't do in the beginning of my introduction, and what I should have done, obviously, is given the format of the
Yeah. We lost Patrick. Casper, I think you have to take the lead.
Yes, so unfortunately, it seems like Patrick had some technical issues with the connection. So I think that we will jump on to some of the many questions that came in for you, and there is quite a number, and thank you for all the questions. I think one of the first ones that came in was about use of IGEL or supraglottic airways in children. What is the standpoint on this, and should that be considered? I think that could be both for Jana and Nigel.
Well, when it comes to the supraglottic airways, this is basically the same as we recommend for intubation. It can be used by competent provider. And we also know that it is more difficult to... Hey, hello, Patrick, are you there again?
Yeah,
So,
something happens with the internet here at the office. There you go.
So I was now trying to answer the question about supraglottic airways in children. So we know that it is easier to get enough expertise in supraglottic airways than it is in intubation, and it really gets a lot of knowledge to be competent intubator of children, I would say. So it basically says the same as the intubation. If you are competent, you can use supraglottic airways in children for pre-arrest and for ALS, but it is the first line recommended is still bag and mask ventilation.
Yes, I would fully agree with what Jana said. There's probably a place for supraglottic airways in a specific situation where bag and mask ventilation is difficult. And it's certainly something we should consider teaching all the advanced providers. Because even if intubation fails, which can happen in the best of hands, one is going to reach for a supraglottic device. So as Jana said, I think supraglottic devices have a very clear place, but bag and mask ventilation remains the mainstay.
Mm-hmm. And Joke Kibom asked, should we then also train the nurses in the pediatric ward in bag and mask?
Well, I believe this is the most important thing to do, that it is now the part of our recommended pediatric BLS, and Dominic can say more about this. So I think this is really important to teach nurses.
We should teach them and retrain them regularly, because unfortunately with the bag you can really do damage to the lungs of children, and it is really important to teach how to handle the bag, and to, I would say, measure what you are doing when you are doing that for several times, because you can really damage lungs.
Mm-hmm.
Yeah, and it's also... Sorry, Patrick.
No, I was just going to say, it's also because there was also a question from Jacques. It's also important to have the right bag. The very small ones will definitely generate insufficient tidal volume. So we would not use them outside the delivery room, these 250 mils bags, but otherwise
they don't use it in delivery room because they have the sustained inflation. They need more volume. And it is true that we should have the right volume. However, what we see most of the time is that people are using a too small bag instead of the right bag. The pediatric bag, and it has been the object of discussion. Should we use the 500 milliliter bag until 12, 20, some manufacturers say 30 kilos. What I don't believe that this is appropriate. And that the small bag should be limited to relatively small children to be sure that we don't hyperventilate them.
Mm-hmm. What I was going to say before I just dropped out was that obviously in the setting of this Congress, we cannot have each of the co-authors of the guidelines in the Zoom meeting or in the presentation, but this was a joint venture of about 12 people who worked very hard. So I would really like to acknowledge each of them for their hard work, because as I said, we did 80 rapid reviews and they spent weeks and weeks working on it. So thank you guys who are not in here for your work. Apart from ventilation, we also had questions on oxygenation. Some doubt what then only giving oxygen below 94% saturation, but what in critical ill children? Jana?
Okay, so basically, if you can reliably measure the SpO2, then you should treat the children with oxygen only if SpO2 is below 94%. But we all know that in emergency situations, sometimes you can't get a reliable curve of SpO2 signal. And in this situation, if you think that the child is in respiratory or cardiac failure, then you can start the oxygen and then you titrate when you get the reliable SpO2. So that's our recommendation.
Okay. There's also been, if I look at it, some discussion by several people saying different things about the 15 compressions to 2 or 30 compressions to 2. People from the adult side say, why didn't you move to 30 to 2 if you want to be uniform? And others say, why do you even allow 30 to 2? For instance, in dispatchers, and knowing that 50 to 2 is better. So I'm curious to hear what you think about it, Dominique.
Well, we have, of course, we discussed that for a long time. When we moved from 5 to 1, if you remember that for the oldest one, we moved from 5 to 1 to 15 to 2. Something like 15 years ago, we were so happy to be in line with adults. And at the same time, in parallel, adults went to 30 to 2. So we were saying, okay, yes, we did it. And adults moved. And we have discussed to go to 30 to 2, but we don't have any evidence. And up to now, the best results we receive is 15 to 2. But we will be very happy to go to 30 to 2 once we have some evidence showing that this is better. We know that children have respiratory problem, and this is the most frequent reason for being in cardiac arrest. We had to increase the respiratory rate for intubated children in cardiac arrest. The reason is very clear. Children have lungs pathology, and this is the cause of the arrest. So probably that's why we need to ventilate them more than adults. And I think we are a little bit stuck with this because of the specific pathology of children in cardiac arrest. Don't know if others have other advice about that.
Mm. And I think we're very much aware of the importance of uniformity, but by splitting it up in the people that are PBLS trained or only adult trained or dispatcher assisted, we actually keep a sort of uniformity that if you're only trained in 30 to 2, that's definitely okay. But if you're specifically trained, doing it in the full pediatric way is the better. So I think it's not conflicting in terms of education as well. Staying with the BLS, Dominique, there's also questions about the use of an AED, and I acknowledge that this is a very, very difficult subject, the use of AED in children versus infants, and maybe also when you have a sudden witness collapse, or when would you definitely use it, and when would you not use it in children, the AED?
Well, you're right. It's quite difficult to decide. The main message we want to give is that our first goal in BLS is to ventilate and do chest compression, and it should never be impaired by or collect the AED or place the EED, because we know, again, 70% of children have respiratory arrest as the cause of their cardiac arrest. So the AED will not help them. So children below the age of 1, generally speaking, have a respiratory arrest cause. If we have a clue of a sort of ventricular fibrillation or whatever, of course, collect DAD like in adults. And we all have stories of children, very young children, who suddenly collapsed and were saved by AED. So as we said, common sense must prevail as always in medicine.
Mm-hmm. In general, this is indeed, it's about common sense, and the general rule still is also for pediatrics, if you have an AED, use it. And especially in those situations where you think it's primary cardiac, it should be your main aim, because that is maybe one of the things that really change outcome. So it's an important part also for pediatrics. Sticking with defibrillation, Nigel, I've seen quite some questions about the joules per kilo, why we stayed with 4, where there was a study of Diane Atkins and all about the 2 joules per kilo thing, and otherwise, if you then increase up to 8 joules, if it goes beyond the adult dose, what then? And also the stacked shock. Finally, what do you think is then immediately available? Pads on or just next to them?
Yes, these are all predictable questions, in fact, which I would have addressed in my presentation, but I was asked to keep to 8 minutes, so I didn't do that. Beginning with the dose of 4 joules per kilogram. Now, Mercier has done the most extensive systematic review of this issue in the last few years, and that suggests that everything between 2 joules per kilo and 7 joules per kilo is effective. That wasn't, to our mind, sufficient reason to change our recommendation. I know other recommendations have been made in the past and maybe are still valid, to use 2 joules per kilogram the first time and then escalate to 4. We found that would be increasing the complexity of the algorithm without any real evidence to do so. That's why we stayed with 4 joules per kilogram for the first doses. As for escalating in refractory VF, that is after 5 unsuccessful shocks, we know that joules to 10 joules per kilogram are fairly safe. At least they don't give much myocardial injury. So we recommended going up to 8. But of course, the maximum dose you will give in an older child, as I think I said, is the maximum adult dose. So that'll be the maximum output of your defibrillator. 200 joules or 360 joules, depending upon the model. And the last question was about stacked shocks, I thought. What is immediately defibrillated?
What do you mean with immediate?
Yes,
available?
we left that in the middle a little bit, actually. Of course, if the child is already on the defibrillator with pads and can be immediately defibrillated, there's no discussion. Then you should do the stacked shocks. In our catheter suite, we have the defibrillator immediately next to the anesthetic machine. I think we can apply the pads within seconds. We always have the machine checked and ready and the pads connected. That sort of situation, I think, is justified to do the 3-shock protocol, the stack shock protocol. If the defibrillator has to come from another area, on the other hand, then I think that's a different matter. I think you should start with thorax compressions. The only possible exception to that is a child following cardiac surgery who may have an open sternum, in which thorax compressions may be ineffective and may also be harmful. But in that situation, I hope the most units would have a defibrillator immediately available. Mm-hmm. So I can't give you an answer in terms of seconds, but that's the general thinking on this issue.
Yeah, and then maybe it's something that we should have captured, but Anatoly, who is obviously very knowledgeable of the adult guidelines, highlighted that in the adults, they already speak of refractory fibrillation after the 3rd shock, while we decided to go for the 5th shock.
Yes, that's true. You and I did that, but I can't remember why.
No, there's no clear definition in the literature. So at that stage, it's a consensus of the working group at what stage. And knowing that we do not have evidence of any, like you said, of any asking for a change in the 4 joules per kilo, we eventually stick with the 4 joules per kilo. The only thing we did is acknowledge that if you come at a point where the likelihood of survival is diminishing and you still have a shockable rhythm, so you still have a potential for outcome, then at some point you need to decide, let's try other things. Let's change the pads or let's go up on the dose. And for us, not going too fast because of the lack of evidence, especially in the pediatric population, we said, when would we define refractory?
Yes, I would agree entirely. The thing is, after the 3rd shock, of course, you are adding an additional intervention, and that is amiodarone. And maybe it would be justified then to wait for the effect of the amiodarone in the 4th shock, at least, before you consider escalating.
And so you would need an extra cycle for the circulation of the amiodarone. So I think indeed that was the main argumentation.
I think also in then here there was a question about amiodarone versus lidocaine. Is it acceptable to use lidocaine instead of amiodarone?
I think we've explicitly said that in the guideline. Indeed, yes. Amiodarone is the first recommendation, but lidocaine is also acceptable for those experienced in its use, is what it says.
And also it depends on what countries have to, and some countries doesn't have amiodarone and some other doesn't have lidocaine, so of course.
Maybe one final question, because we are closing in. There's a lot of interesting questions still. If you have specific things you want to ask, just mail us without any problem. I wanted to end with because that's in a way a big change with the 2-thumb encircling. A lot of people saying, is this really also for the single rescuer, and will this not delay resuscitation or add pauses? Is it technically feasible?
Well, I'm sure this is not that easy, but two fingers is not that easy either, because it's really tiring to do that. So if you are single, doing that for 1 or 2 minutes, probably if you try that on a real baby, it's really hard, and you are not that powerful to do that. So it is true that the 2-thumb technique is much more easy, much less tiring, and I'm sure that people will be very happy to move. And well, we can use both.
I think there's also, again, a big difference between those PBLS trained and those only adult trained or untrained dispatcher assisted, because we do not strongly advocate this for the untrained, It's an option, but I can presume, and there's no data about it, that it might be difficult to explain via the telephone how to do two-thumb encircling, especially in people that are, for instance, only adult trained and are used to use hand compression or finger compression. But especially for those PBS trained, we have the opportunity to really train them in the two-thumb encircling technique. And that's the way we should move forward, I think. Very well. I think, Casper, we are at the 11:30 hour. It's been, I think, a very interesting and a very lively sessions. I thank the audience also for all their questions and comments. And I think we could discuss this for a few hours still to go. I thank you, Casper, for being with us. And I thank, obviously, Jana, Nigel, Dominique, and all co-authors of these pediatric guidelines on which we worked for like 3 years or so. Thank you very much. See you in the next sessions. We have a session about how to restart courses, also pediatric ones, in the afternoon. Stay tuned, be there. Bye-bye.
Bye-bye.
Bye.